Thank you, Chairman. I'm Hee-Joon from South Korea. In most important clinical trials, patients with mild symptoms are usually excluded, and current stroke guidelines do not recommend intravenous thrombolysis for minor stroke symptoms. However, if not treated, clinical outcomes of patients with mild symptoms are not always good. A third of them have poor functional outcome. Previous studies showed that a favorable outcome, defined as long-term ranking scale at 3 months, 0 to 1, was found in 80 to 90% with a low incidence of symptomatic intracranial hemorrhage with intravenous thrombolysis. However, those studies had limitations. They had a small sample size, historical controls or no controls, and no adjustment for baseline imbalances between the IVT and no-IVT group. Furthermore, the recent International Stroke trial showed that in their subgroup analysis, no beneficial effect of IVT over no treatment in patients with mild stroke. Our study hypothesis is that the IVT would be more effective in patients with mild stroke symptoms compared with no treatment. To prove this hypothesis, we compare the effectiveness and safety of IVT over no treatment in ischemic patients who presented with a mild neurologic deficit within the 4.5-hour onset by analyzing the prospective stroke registry CRSS-5 database from the 12 stroke centers in Korea. CRSS-5 was funded by the Korean government. It began to collect the clinical information on hospitalized stroke patients since 2008. The details of the registry was published last year in International Journal of Stroke. Eligibility criteria as are equal as shown. We included patients who arrived within 4.5-hour onset and whose initial NHS stroke scale was 5 or less. And we excluded patients who were treated beyond the time window or treated with endovascular therapy. Among the 13,000 acute stroke patients registered in the database, we identified 1,384 patients who met the eligibility criteria, and they were analyzed for this study. Primary outcome measures of favorable outcome defined as MRS 0 to 1 at 3 months, and safety outcomes are 3 months mortality and symptomatic hemorrhagic transformations. To overcome the expected imbalances between the IVT and no-IVT group, we adopted 3 strategies. 1, multivariable logistic regression models. 2, use a propensity score with 1 to 2 matching with propensity score. 3, additional adjustment for the variables with absolute standardized differences in mean more than 0.1 after matching. Sensitivity analysis was performed by applying the NISDP stroke studies exclusion criteria of minor stroke. Among the 1,348 patients, 194 patients were treated by intravenous thrombolysis. Age was 64 years old and weight was 64%. As expected, the IVT group arrived earlier than the no-IVT group, and they had a higher initial NHS stroke scale than no-IVT group. The other characteristics are not different between the 2 groups. The blue line is the proportion of patients treated with IVT among centers. As you see, the proportions vary markedly among centers. from 0% to the 35%. I think this slide showing the discrepancy of whether we treat a stroke patient or not. We selected absolute standard differences mean as a measure to represent the between group differences. Before matching, they are market differences, market among centers, but with matching they improved. But still, the differences existed for initial NIH stroke scale, onset of arrival time, clear onset, and use of MRI. So we did those 4 variables was used for additional adjustment after matching. This slide is showing the distribution of propensity scores before and after matching. As you see, there is a marked improvement in imbalance between treated and not treated group. 3 months MRS 0 to 1 was 71% in the IVT group and 75% in the no IVT group. The crude oil ratios is 0 to 0.75. However, with multivariable logistic analysis and all the PS matching or PS matching with additional adjustment, the odds of the favorable functional outcome at 3 months increased up to significantly increased by the intravenous thrombolysis. Symptomatic hemorrhagic transformation occurred 4.1% in the IVT group and 0.1% in the no IVT group. The crude oil ratios were over 8 and with adjustment, it lost its statistical significance. But you can see some trend to increase of symptomatic hemorrhagic transformation by IVT. 3 months mortality was 1.0% in the IVT group and 1.9% in the no IVT group. The crude and adjusted analysis showed some tendency of reduction of mortality by the intravenous thrombolysis, although they are all not statistically significant. Exclusion of patients who met the minor stroke criteria of the NIH TPA trial did not change the literature. So with respect to MRS at 3 months of 0 to 1 or symptomatic hemorrhagic transformation, the tendency was preserved. The IVT increased the odds of the favorable functional outcome with adjusted analysis or PS matching, and the symptomatic hemorrhagic transformation tended to increase, although not significant. This comparative effective analysis based on the prospective multi-center stroke registry database showed the meaningful effectiveness of IVT for mild ischemic stroke compared with no treatment despite the increased risk of intracranial bleeding. This is not a clinical trial. It is just an observation study based on the multi-center stroke registry database. So we are very cautious to generalize the study vision. But we think this study can justify the necessity of the randomized clinical trial to test our study hypothesis. Thank you for your attention.
This paper is now open for questions.
It's Timo Siegmann from Dresden University Hospital. Thank you very much for the excellent talk. And quantity of the symptoms, the NIHSS score, or also differentiate between groups of patients who have disabling deficits such as motor aphasia, and people who might have the same NIHSS score but a lesser degree of disability.
That is a very important question, but that's why we perform the sensitive diagnosis excluding the patients who met the NIH stroke trials and minor stroke criteria. So I can answer what is the important features who will obligate or have a bad outcome in our population. That is what we have a plan to look at in usually.
Thanks.
For that.
David Mutoker, Johns Hopkins. Thank you very much. Very elegant talk. My question to you is about the patients that made it into this discussion in your database. So, for instance, do you think that patients with, for instance, isolated dizziness or vertigo type presentations made it in, or was it only people who had low scale scores, but people were confident that they had, an isolated sensory defect or something else that was, a heavy sensory problem, that they were highly suspicious of a stroke? Do you think it was more inclusive or less inclusive as a population?
This registry contained all the patients who had ischemic lesions and brain diffusion MRI. All those population is compounded by the neuroimaging stroke patients. But as you know, some of them has just mild disease and they made no problem. That is, I think that is your question is very similar to the first one. So at this moment, I think we start with the NIH clinical trial minor stroke criteria. It is the baseline start point. But if we know more, we should look into the other profiles such as the angiographic occlusion of the major cerebral arteries and so on.
Thank you. Last question. Robert, check on the picture. I had a question about if you had a vascular imaging. Maybe you just mentioned that.
Pardon?
Did you have a vascular imaging? I mean, did you have an analysis of some group of patients that had occlusion, for example, CT angiography? Because I would expect about 20-30% with an ISC scale below 5 might have the occlusion.
CSO means symptomatic occlusion, standard occlusion of major cerebral arteries. It means that the profiles of the angiographic result is included in the model. But I can't remember exactly it is significant on that, but I hope in my memory it is not a significant predictors of the good outcome in this model.